Good evening. Welcome to another International Dermatology Education Foundation Educational Series webinar. My name is Roxanne Chabot from RBC Consultants. This evening, we're going to be talking about mild to moderate atopic dermatitis in skin of color patients. Our moderator this evening will be Dr. Leon Kircik, President of the International Dermatology Education Foundation, Clinical Professor of Dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and Medical Director of Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. Our speaker this evening is Dr. Heather Woolery-Lloyd, who is Director of Skin of Color Division at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, University of Miami Miller School of Medicine in Miami, Florida. We'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. With 1 to 2 days of the webinar, a survey link will be emailed to you. We'd greatly appreciate it if you could fill out this very short survey. So please submit your questions using the question chat pane on the right-hand side of your screen, and I wrote a little note there so you could see where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Kircik.
Good evening, everyone, and thank you for joining us tonight. We are very lucky to have a special guest tonight from down south, University of Miami, Dr. Heather Woolery-Lloyd. So next slide, please. But before we go there, I'd like to tell you a little bit about the goals of International Dermatology Education Foundation. We are a nonprofit organization with a principal mission of raising awareness and improve dermatology care all over the world through education, especially in underserved areas. Next. So we have done several educational sessions during the pandemic when we started our webinars, and we have done not only in the US, but in North America, in Southeast Asia, in South America, and all over the globe. Tonight, as I mentioned earlier, we are very lucky to have Dr. Heather Woolery-Lloyd from University of Miami Dermatology Department. Welcome and good evening. Thank you for joining us tonight, Heather. Please take it from there.
Thank you so much. I'm really excited to give this talk, which I'm going to take control. There we go. Which is on mild to moderate atopic dermatitis in skin of color patients. So this talk is a promotional presentation. It's sponsored by Incyte Corporation, and I'm speaking on their behalf. I'll be going over my talk is consistent with the US FDA regulations, and I'll be discussing data that's on the US FDA approved label, and I'll be able to answer questions that are on label. I'll be presenting important safety information, and the full prescribing information for Opzelura is available on request. So let's talk about the indications for usage. Opzelura is indicated for the topical, short-term, and non-continuous chronic treatment of mild to moderate atopic dermatitis in non-immunocompromised adult and pediatric patients 12 years of age and older whose disease is not adequately controlled with topical prescription therapies or when those therapies are not advisable. So we know that it's FDA approved for atopic dermatitis patients 12 years of age and older, and that's what I'll be focusing on today. But there is actually a second indication, which is for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. There is a limitations of use statement, so the use of Opzelura in combination with therapeutic biologics or other JAK inhibitors or potent immunosuppressants is not recommended. So I'm going to start this talk with important safety information, and we're going to end with important safety information. So this is the general class label for JAK inhibitors. JAK inhibitors, as many of you know, were actually first introduced into the rheumatoid arthritis world and was that was the first disease that JAK inhibitors were used for. So there is some general label information that applies to all JAKs that is based off of the original data from rheumatoid arthritis. So serious infections leading to hospitalization or death, including TB, bacterial, fungal, viral, and opportunistic infections, have occurred in patients receiving JAK inhibitors for inflammatory conditions. So we definitely want to monitor our patients for infections. High rate of all-cause mortality, including sudden cardiovascular death, has been observed in patients treated with JAK inhibitors for inflammatory conditions. Lymphomas, malignancies, and higher rates of MACE, which is major adverse cardiac events, have been observed in patients treated with JAK inhibitors for inflammatory conditions. And when it comes to the malignancies, basal cells and squamous cell carcinomas have occurred, so we would do our routine, normal, periodic skin examinations that we do in all of our patients. And then thrombosis, including deep venous thrombosis, pulmonary embolism, and arterial thrombosis, some fatal, have occurred in patients treated with JAK inhibitors for inflammatory conditions. So as I mentioned, this is a general overview of JAK inhibitors, and then at the end of the talk, I'm going to dive a little bit deeper into important safety information specific to the clinical trial. So atopic dermatitis is something that we all treat every day, and it's especially common in our skin of color patients. And when you look at the data, in the overall population, up to 13% of children in the US have atopic dermatitis. And of those children with atopic dermatitis, 65% have mild disease and 35% have moderate severity or higher. And we kind of always tell our patients, well, when we see pediatric patients, most people grow out of it. And although that is true, up to 10% of adults in the US have atopic dermatitis, and those can be people who had it from childhood or get new onset atopic dermatitis as an adult. I definitely see that in my practice. Now let's jump over to the side over here talking about the Black population. So as mentioned, I'm the director of the Skin of Color Division. I see a large Black population, a large skin of color population in my practice here in Miami. And atopic dermatitis is definitely more prevalent in Black patients in studies and also what we just observe in clinical practice. When you look at the pediatric population, 18% of Black children compared to 11% of white children have atopic dermatitis. And then in a different study, Black and multiracial children had more persistent AD, and we definitely observe that in clinical practice. So not only do we see increased prevalence of atopic dermatitis, but we also see more persistent and in some ways more severe disease in a lot of our skin of color patients. And when you look at the US as a whole, over 30 million people in the US are estimated to have atopic dermatitis, and over 21 million are 12 years of age and older. And this is expected to increase. This doesn't surprise me. I feel like I see atopic dermatitis more and more. People have much more sensitive skin. There are many theories for this, but it's definitely on the rise. So when we think about our atopic dermatitis patient, the number one clinical symptom that is burdensome to those patients is itch. The patients complain of itch. And when they look at atopic dermatitis patients, over 55% of patients with mild to moderate disease report that itching and scratching is the most burdensome disease symptom. And interestingly, and not surprisingly, some pruritic conditions, including atopic dermatitis, are more prevalent in Black and Asian patients. And in a different study, they found that among patients who presented with pruritus, Black patients were 50% more likely to be diagnosed with atopic dermatitis. So when I kind of summarize all of this information, we know that atopic dermatitis is more common in Black patients, it's more severe in Black patients, and itch appears, pruritic conditions, including atopic dermatitis, appear to be more common in Black and also Asian patients. So when it comes to atopic dermatitis and skin of color, we have limited information, but the great news is that that data is growing. So information on skin of color patients is underrepresented in our physician training resources, but that is definitely changing. When you look at images of dark skin in textbooks, they comprise maybe 4 to 18% of patient images. But again, I'm hoping that that will change where we see representations, particularly of atopic dermatitis in darker skin types in the dermatologic literature. And when patients are asked, what they value Black participants value dermatologists who are demonstrate knowledge in the care of Black skin and hair. So the great news is that education in skin of color is really on the rise. It's changed dramatically over the last 20 years. And this is a real opportunity for growth for us to increase our knowledge, increase our resources on atopic dermatitis and skin of color. So when our patients present with skin of color, they have a distinct clinical presentation. One of the common things I see, especially in pediatric patients, is follicular accentuation. So you see this follicular pattern, sometimes on the elbows, you'll see that, or on the extremities, this more follicular lichenoid presentation of atopic dermatitis. We also see lots of involvement of those extensor surfaces. That's much more common in our skin of color patients. Lichenification is a big one. I think this could be because these are very itchy patients, and of course, chronic itching and chronic scratching leads to lichenification. And then when atopic dermatitis presents, instead of being that typical bright pink or bright red color that is often presented in darkly pigmented patients, that erythema can be reddish brown, it can be violaceous, it can even look a little bit gray. So it's harder to discern or to distinguish that erythema because of the background pigment in the person's skin. And then, of course, there's post-inflammatory changes. So people can get post-inflammatory hypopigmentation that you can see on this slide, or you can get post-inflammatory hyperpigmentation, and both are very common in our eczema patients. So when we look at diagnosis and treatment in some skin of color patients, there are some challenges. So as I mentioned, erythema presents differently. And I do a lot of clinical trials in atopic dermatitis. And in a type 6 skin, it's sometimes very difficult to detect that erythema because of the constitutive pigment in that person's skin. So a lot of times in clinical trials, we're often instructed to actually grade up so we capture that erythema in skin of color patients, because oftentimes the severity of erythema can be minimized, and the severity, they can be underscored. So it's something that we would be very, very aware of to make sure we're accurately scoring these patients in trials. Also, if you're using narrowband UVB in your practice, obviously the darker skin patients might require higher doses. And then, of course, those pigmentary changes that we see in our eczema patients, some are post-inflammatory, but also topical steroid use can cause hypopigmentation, and sometimes patients will complain of that. And overall, some studies suggest that Black patients with atopic dermatitis report poorer disease control. So we definitely can do a better job at treating these patients. So when you look at the genetics behind atopic dermatitis, we really see that historically it was considered a Th2, Th22 centric disease based on European American adults. But there are different immunological phenotypes in different ethnicities. So compared to European Americans, the Asian patients have been reported to have higher Th17, Th22 pathways, and Black patients have been reported to have attenuation of the Th1 and Th17 pathways. So we definitely need more research. I don't think this has been totally teased out yet and is very clear, but we definitely need some more research to understand and clarify the immunological differences in atopic dermatitis in different racial ethnic groups. So in addition to, that concern, the presentation is different, the immunology is different. I think that this slide is really interesting because we don't have data on the efficacy of common therapies. So, when you look at skin of color representation in clinical trials for drugs that have been approved for atopic dermatitis, many times skin of color patients are underrepresented in those trials. So we have very few trials that specifically interpret efficacy data in different racial ethnic populations. So even though atopic dermatitis is much more common and much more severe in Black patients, we don't know all of these drugs that are FDA approved for atopic dermatitis. We don't know if they work better in those patients or worse in those patients or similarly in those patients because they weren't powered to look specifically at that subtype. So despite differences in the clinical presentation and this immune profile, we don't have any specific guidance or algorithm specifically to treat atopic dermatitis. And I kind of liken this to hypertension. Hypertension is a disease that's much more common and much more severe in Black patients. And in medical school, we were all told that thiazide diuretics are first-line therapy for hypertension in Black patients. And that's because of the data based on the clinical research, of that time. So I'm looking forward to a time where we really do have more solid data on what works better, what works, what might be first-line therapy for a Black patient with atopic dermatitis. So I think this is a really exciting time because I think that research is being prioritized now, and we will hopefully in the future, just like we do with hypertension, have algorithms that are best suited based on if there are differences based on different racial ethnic groups. So now we're going to jump into talking about Opzelura, which is ruxolitinib 1.5% cream. And I'll talk a little bit about the mechanism of action. So this is the first topical JAK1, JAK2 inhibitor. And when we look at atopic dermatitis, there are a lot of key cytokines that are involved. So IL-4, IL-13, IL-31, and TSLP. All of these are really important in the pathogenesis of atopic dermatitis. So I think that JAK inhibitors are becoming much more common, and understand the mechanism of action, but I'll go over it briefly. So JAK inhibitors are small molecules, and you can see here they're on the inside of the cell. So they're on the inside of keratinocytes, and they're on the inside of CD8 positive T cells, and they how JAK inhibitors work is they block activation of that JAK-STAT pathway, and the STAT goes to the nucleus, would normally go to the nucleus and tell the nucleus to produce all of these inflammatory cytokines, but in the presence of a JAK inhibitor like Opzelura, it stops that process, and you basically reduce that signaling from IL-4, 13, 31, and TSLP, which are all believed to contribute to itch and inflammation in atopic dermatitis. So that's how JAK inhibitors work. Now let's jump into the clinical trials and the data from the clinical trials. So there were 2 phase 3 randomized double-blind studies in adult and pediatric patients 12 years and older, and these patients had mild to moderate atopic dermatitis. So I'm going to go through this slide, which might be a little bit busy to you. So I'll just start from the left. So first of all, what were the inclusion/exclusion criteria? So basically, patients had to be 12 years of age and older. They had to have atopic dermatitis for at least 2 years. They had to have an IGA score of 2 or 3, which was mild to moderate. And they had to have a BSA between 3% and 20%. So that's how you got enrolled into the trial. And then there were 3 cohorts. So they were randomized to either 0.75% ruxolitinib, 1.5% ruxolitinib, which is what Opzelura is, or the vehicle. And they were followed for 8 weeks, and the primary endpoint was at 8 weeks. And then at that point, we flip over to the long-term safety period. So at week 8, we're going to look at the data at week 8, and then at week 8, the people in the vehicle group were randomized either to Opzelura or the 0.75% ruxolitinib. And then you see this little circle here. So what happened in this long-term follow-up? So I think this is actually really well designed, because what they did was exactly what we tell our patients in clinical practice. The patients got better by 8 weeks, and then at that point, if their lesions were clear, they could stop treatment. Like you can see here, a lesion clear in light blue, they could stop their treatment. But if the lesion recurred, they could restart again, and they would restart the treatment until they were clear again. And when they were instructed to stop the treatment 3 days after they were clear. So if the lesion cleared, they could stop the treatment 3 days later and then not use it until it flared again. So this mimics what we do in clinical practice, which is basically as needed. And that's what this long-term safety period looked like. So let's look at some of the demographics. The mean age was in the early 30s in both the Opzelura and the vehicle group. A lot of women in this trial, around 60, a little over 60% women. And you can see here that there was a nice skin of color population. So around 30% of the subjects were Black, Asian, or other. They did not capture Fitzpatrick skin type data in this trial, but we do know that around 30% of subjects were Black, Asian, or other. The mean BSA in the trial was 9.6 for both the vehicle and for Opzelura. The mean EASI score was 7.8 for both groups. Most patients were moderate, with 75% being moderate and around 25% being mild. And then we're going to talk about the itch NRS score. So if you're not familiar with that, it's a score to measure the level of itch, and they're basically asked the patient, please describe your level of itch in the last 24 hours. I'm on a scale from 0 to 10. So an itch NRS score gives you an assessment. It really reflects quality of life because, as we mentioned earlier, itch is the most burdensome symptom for most patients with atopic dermatitis. So in this study, the mean NRS at the baseline was 5, and the patients who had an NRS of greater than or equal to 4 was 63%. So most patients had pretty significant itch in this study. The duration of disease was 16 years on average. Around 39 to 37% of patients had facial involvement, and on average, they had around 6 to 7 flares in the last 12 months, so 6 to 7 flares a year. Now, I'll go over this slide in a little bit of detail because I know there's a lot of information on here, but I want to go over it so that you can really understand this data because it's quite impressive. So the proportion of patients achieving an IGA TS, TS stands for treatment success, at 8 weeks is defined as patients who had a 2-point improvement and were clear or almost clear. So when you look at this graph here, this table, you can see here that these 2 purple lines are just the Opzelura group. So we don't have the 0.75% group in here, we just have the Opzelura, the True 81 and True 2. So you can see here that 51 to 53% of subjects, so over 50% of subjects, achieved that endpoint of treatment success, which is a 2-grade improvement and clear or almost clear at week 8, significantly more so than the vehicle. Now let's look at that long-term safety, because this is what I think is most clinically relevant, because the question is, they got better, which is fantastic, but what happens long-term, you know, because remember, they could use this medicine as needed. So you can see here, again, that over 70% of patients were clear or almost clear at the end of 52 weeks. And that included the people who started on the vehicle, because remember, a third of the patients started on the vehicle and then were switched over to active at week 8. So including those subjects, you can see them here, they start low and kind of jump up here. At the end of the study, at week 52, over 70% of subjects were clear or almost clear. And I think that that's very significant because it reflects real life usage, which is basically as needed. And this is just one of the subjects in the trial. You can see at baseline, their IGA was 3. At week 2, their IGA dropped down to 1, so that was a 2-point improvement. And then at week 8, the investigator still rated them with an IGA of 1, which is almost clear. Now, remember, we talked a lot about itch, and itch is a measure, I think of it as a measure of quality of life in some ways. And these are the proportion of patients who achieved an itch NRS 4. So what does that mean? That means a 4-point improvement in the NRS scale. So that means if they had an 8, they dropped to a 4. If they had a 4, they dropped to a 0. So it's a 4-point improvement in their NRS. And why is itch NRS 4 significant? It's significant because that's considered a clinically meaningful improvement in itch. So when you look at the itch NRS 4 in the first 8 weeks, you can see that 50% of subjects achieved that itch NRS 4 in the first 8 weeks of the trial. Now, what's also significant is how quickly that itch got better. So this little graph over here shows us the first 7 days. And you can see in the first 7 days, you can see here at day 7, 36% of patients had an itch NRS of 0 or 1, so almost no itch in just the first 7 days. And you could see improvement as early as day 2. So it's a really, I think, clinically relevant graph that we're looking at here, because it's wonderful that the eczema got better, but I think what's often most important to the patient is the itch, and we really see a significant improvement in itch in this clinical trial. So just as important as efficacy to me is safety. Safety is very, very important. As I mentioned, I do clinical trials for a living, so I'm always very focused on safety. And these were the treatment emergent AEs that were reported in the Opzelura trial through 8 weeks. So this is the 8-week data. So you can see that the most common treatment emergent AEs were nasopharyngitis, bronchitis, ear infection, eosinophil count increase, urticaria, diarrhea, folliculitis, tonsillitis, and rhinorrhea. Those occurred at a rate of 1% or higher. And then the adverse reactions that occurred at a rate of less than 1% versus 0% in the vehicle were neutropenia, allergic conjunctivitis, pyrexia, seasonal allergy, herpes zoster, otitis externa, and staph and acneiform dermatitis. So there are two other important bullets that you can see here at the bottom of this slide. One of them is the application site reaction. So in general, in eczema trials, we are very concerned about the actual medication causing itching and burning because our eczema patients are so sensitive. And I think interestingly, the rate of burning with Opzelura was 0.8% versus 4.4% with the vehicle. And the rate of pruritus due to application was 0% with Opzelura compared to 2.4% with the vehicle. So this is very well tolerated in our ultra-sensitive atopic dermatitis patients, and very few patients discontinued due to treatment emergent AEs, 0.8% in the Opzelura group versus 3.2% in the vehicle group. Now let's look at the treatment emergent AEs through 52 weeks. So you can see here that at the end of the trial, that long-term safety trial, these are the most common treatment emergent AEs at greater than 2%. So those were upper respiratory tract infection, nasopharyngitis, headache, bronchitis, influenza, rhinitis, atopic dermatitis, and asthma. And so it's very well tolerated, and these this data is based on people who are all using the drug. So we don't have a comparison to the vehicle here. Now I'm going to jump into the subgroup analysis in Black patients. So in this deck, we've pulled out the Black patients that were treated in the trial, and we're going to look at the data in those patients. Now, it's very important to understand before we jump into this, that this data is just for observation. We can't really draw any conclusions because the trial was not powered for us to draw conclusions on the subgroup analysis, but it's interesting information to have, and I think that we should take a look. So the mean age of the Black subjects in this trial was similar, around 31 to 36 years old, the 31 in the vehicle, 36 in the Opzelura group. Again, mainly women, a little bit higher, 67 to 72% women. The mean BSA was 8.2 and 8.7 in the vehicle. EASI score was a little lower. It was 6 in both groups. And then this subgroup analysis had more mild disease. So 34% of subjects, around 34 to 39% of subjects were mild, and around 60 to 65% were moderate. In the whole group, it was more like 25-75 to give you a frame of reference. The itch-NRS score, the mean itch-NRS was similar at 5. So people started the trial with an itch score of 5. And remember, that scale is from 0 to 10. And then for the people who had an itch-NRS of greater than 4, a lot of patients, around 65% of patients had an itch-NRS of greater than 4. On average, they had the disease a little bit longer, 17 to 18 years. In the other trial, it was a little closer. It was a little less than that in the whole group, in the total group. Facial involvement was seen in around 23 to 24% of subjects, and the number of flares in 12 months was between 5.7 and 6, depending. In Opzelura, it was 5.7 and 6 in the vehicle. So these are the demographics. So what are the take homes that we see here? First of all, remember this subgroup analysis is not for anything for us to draw conclusions from. It's just interesting data for us to look at because it was not powered to show efficacy or safety specifically. But let's look at the patients of the proportion of Black patients who achieved an IGA treatment success at 8 weeks. And remember, an IGA treatment success is clear or almost clear, and a 2-grade improvement in their global assessment by the investigator. So in this trial, in this subgroup analysis, 38% of the Black subjects met that endpoint. In the total group, it was around 50%. So the one thing I do want to point out here, although we can't draw any conclusions, is that remember, more patients were mild. So to get the clear or almost clear, you have to go from mild to completely clear. which is actually more challenging than going the 2-grade improvement from moderate. So that could account for this difference. But the one thing I will say is when you look at that long-term safety, the IGA of 0 or 1 is similar. It was around 70%. So this is what we saw in the total group. It was 70% of subjects achieved that IGA of 0 or 1, which is clear or almost clear at the end of 52 weeks. So I think this is very interesting data, but it's important for us to understand that this is just a post hoc exploratory analysis, and we can't really draw specific conclusions because it wasn't powered to do that. So this is just a real world patient. This is a 33-year-old Black woman who presents with hypopigmented pruritic eczematous patches, and this patient had a BSA of 14%. She has an IG of 3 at her baseline. And then at week 6, this is not from the trial, this is photos courtesy of Dr. Jason Smith. At week 6, her IGA has gone down to 1. You can see significant improvement in her eczema in this picture. So let's talk again about itch, because itch, as I mentioned, is the thing that our patients are most concerned about. So the proportion of Black patients achieving an itch NRS of 4, and to refresh your memory, that's a 4-point improvement in the NRS at the end of 8 weeks. And you can see that 43% of subjects achieved that itch NRS of 4 of these Black subjects. And then at the end of 7 days, the subjects who achieved an itch NRS of 0 or 1, which means they had almost no itch at 7 days, was 34% of subjects. So again, really, what we're seeing this trend is that Opzelura appears to really impact itch, which is the symptom that's most burdensome in our atopic dermatitis patients. Now, this is a very interesting slide because it looks specifically at sleep, okay? We talk about itch, but one of the things we consistently hear from our patients is that they can't sleep because they're itching. So I know this looks a little bit complicated, but I'm going to focus on the purple here. So basically, it's looking at the proportion of patients in each category who describe that the itching at night disturbed their sleep. So at the beginning of the trial, very few people were sleeping well. Let's put it that way, where no nights did their itch disturb their sleep, right? Or their eczema, did their eczema disturb their sleep? But what you can see here at the end of 8 weeks, for most patients, 66% of patients in that time period over the last week, now many of them are having no nights where their eczema is affecting their sleep. So I think this is really interesting because in just 8 weeks, that it can be a dramatic improvement in quality of life. Now, when you look at the long-term safety, you see that similar change where you can see it go up and down. That's probably because, remember, this is as needed, so this is over a period of a year. But you can see that overall, patients in general are sleeping better, where their eczema is not interrupting their sleep over the last 7 nights. These types of pieces of information, to me, are just as important as the efficacy data, because that's what really impacts patients' quality of life, their itch and how much they sleep at night. I mean, for all of us, that's so important. Sleep is important. So I really love that this information was captured, and we can see that there is improvement in sleep when we treat eczema effectively. Now let's talk about the adverse events in the Black patients during this 8-week vehicle-controlled period. So you can see here, application site pain was 0 in this Black subgroup analysis and 3 for the vehicle. Headache was 1.8% in the Black patients and 1.6% in the vehicle. Upper respiratory infection was 2.7% and 1.6% in the vehicle. And cough was 0 in this Black subgroup on Opzelura, 3.3% in the vehicle. Now let's talk about the treatment-related AEs. These are the ones that the investigator felt were related to the medication. And you can see there were 4 treatment-related AEs in this subgroup analysis of patients on Opzelura, or 3.5%, and 8.2% of treatment-related AEs in the vehicle group. Patients who discontinued due to a treatment AE were 0 in the Opzelura group and 1.6% in the vehicle group. And patients with serious treatment emergent AEs were 0 in both groups. So as I know, I keep mentioning this is a subgroup analysis. It's not powered for us to draw any conclusions, but you can see that the safety data is very acceptable here. Now let's look at the 52-week data. And you can see that upper respiratory tract infection was at around 9% in the Opzelura group, 4.5% in the vehicle. Hypertension, which as I mentioned is very common in our Block patients, was 5% in the Opzelura group and 4.5% in the vehicle. Bronchitis was 5% in the Opzelura group, but not observed in the vehicle. And then neutropenia, anemia, influenza, nasopharyngitis, and headache were between 1 and 3%. And in the vehicle, the anemia and influenza were 0, nasopharyngitis was at 9%, and the headache was at 4.5%. Now, the treatment-related AEs, those are the ones that the investigator felt was related to the treatment, was 6.2% in the Opzelura group and 9% in the vehicle group. Remember, these investigators are blinded. And of course, patients who discontinued due to treatment emergent AEs or serious treatment emergent AEs were 0 in that 52-week long-term safety trial. So what can we conclude? So we know that Opzelura is the first and only topical JAK inhibitor. It's indicated for the short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis in adult and pediatric patients 12 years of age and older. So the good news about that is that it is really, I love that we have this 52-week data that kind of mimics what we do in clinical practice, that as-needed use that we often do. And I love having that nice long-term safety data. How does it work? It works on targeting the signaling of cytokines, so IL-4, 13, 31, and TSLP, which all contribute in some ways to itch and inflammation. So when you look at clear or almost clear for the whole population, not in the Block subgroup, but the whole population, at week 8, over 50% of patients were clear or almost clear. And even 25% of patients, over 25% of patients were clear or almost clear as early as week 2. And then a very important piece of information, which is the itch NRS4, which is the 4-point improvement in itch, was seen in over 50% of patients at week 8. So most patients had clinically meaningful improvement in their itch. So over 30% of patients achieved the itch on NRS4 at week 2. That means in 2 weeks, they had that, over 30% of patients had that clinically meaningful improvement in itch. And that improvement was seen as early as day 2. And in the additional exploratory analysis, patient reported an itch NRS as improvement as early as day 1 through 56. So what this data is showing us is that there is a significant improvement in itch, which is the most burdensome symptom in our patients with atopic dermatitis. Now, as far as safety, the most common adverse reactions at greater than 1% were nasopharyngitis, bronchitis, ear infection, eosinophil count increased, urticaria, diarrhea, folliculitis, tonsillitis, and rhinorrhea. And overall, we have to think of this drug as a non-steroidal, so safe for sensitive areas. They were used on the face and the underarms in sensitive areas, injection-free, and is appropriate for use, as I mentioned, in sensitive areas. So this is something that can fulfill a need in our patients with mild to moderate atopic dermatitis who are not doing well with our conventional therapies. So as I mentioned, I told you I would start and end with important safety information, and I will go through this kind of pointing out what is specific to the class and specific to Opzelura. So as we mentioned, serious infections have been reported with JAK kinase inhibitors, and those include TB, fungal, bacterial, viral, zoster, and other infections. So we would avoid using Opzelura in patients with active serious infections, including localized infections. If your patient were to develop a serious infection, you would just consider discontinuing it or weigh the risks and benefits, but would most likely discontinue the Opzelura and monitor the patients for signs of infection. So there were no active cases of TB in the clinical trials with Opzelura. There were some cases of viral reactivation of herpes virus, herpes zoster. So that's been reported with all JAK kinase inhibitors and also with Opzelura. So if a patient develops zoster, you would consider interrupting Opzelura. Hepatitis B titer increases have been observed in patients treated with JAK inhibitors, although not with Opzelura, and Opzelura initiation is not recommended for anyone with active hepatitis B or C. Now, when it comes to mortality and malignancy, these are based on these post-marketing studies of the rheumatoid arthritis patients. So these were these very large randomized post-marketing studies of rheumatoid arthritis patients 50 years of age and older with at least one cardiovascular risk factor, and they were taking an oral JAK and they were compared to people taking TNF blockers. And in that trial, there was a higher rate of all-cause mortality, including sudden cardiovascular death, in the JAK inhibitor group. So you'd consider the risks and benefits of each individual prior to initiating Opzelura. For malignancies, it was the same thing that was reported in that large post-marketing trial. So in RA patients treated with an oral JAK compared to RA patients treated with a TNF blocker, there was a higher rate of malignancies. And malignancies were reported in patients treated with Opzelura. So again, in patients who are current or past smokers, there is an additional risk. So you would definitely take that into account if you have a patient who's a current or past smoker and consider the risks and benefits in initiating Opzelura in these types of patients with no malignancies or smokers. Non-melanoma skin cancers, including basal and squamous cell carcinomas, have occurred in patients treated with Opzelura. So we would do our routine skin checks that we always do and tell our patients to use sun protection and sun avoidance. And then major adverse cardiac events or MACE events, again, in that large post-marketing study of RA patients 50 years of age and older with at least one cardiovascular risk factor there, and they compared them again to those TNF blockers, there was a higher rate of major adverse cardiac events like MI and stroke. So we would again take into account if our patients are at high risk or current or past smokers. And again, thrombosis has that same information. So thromboembolic events were observed in all patients on JAK inhibitors, but also in patients using Opzelura. So if a patient is at high risk for thromboembolic events, we would consider those risks and benefits in those patients. And this is the last slide looking at the important safety information, and it focuses mainly on lab data. So thrombocytopenia, anemia, and neutropenia were reported in the clinical trials with Opzelura. So you would consider the benefits and risks of patients who have a known history of severe anemia or thrombocytopenia before initiating therapy with Opzelura. And then you can perform CBC monitoring as clinically indicated if you choose to do so in your practice. But that's a personal choice. Lipid elevations have been reported in patients on oral ruxolitinib. So, and these include total cholesterol, LDL, and triglycerides. So it's something to consider if you have a patient who is at high risk of lipid elevations. And as I mentioned, the most common adverse events in this trial for atopic dermatitis were nasopharyngitis, diarrhea, bronchitis, ear infection, eosinophil count increase, urticaria, folliculitis, tonsillitis, and rhinorrhea. And for the non-segmental vitiligo, they were similar: nasopharyngitis, headache, urinary tract infection, application site erythema, and pyrexia. When it comes to pregnancy, we don't really give our pregnant patients anything. So, you know, we would not use Opzelura in our patients who are pregnant. There is a place where you can report patients if they are pregnant and have been exposed to Opzelura. And of course, we wouldn't use Opzelura in patients who are breastfeeding. So in summary, this is a twice daily application to up to 20% of the body surface area. You would instruct your patients not to use more than 60 grams in a week, but very rarely do patients do that, especially because we're only treating up to 20% body surface area. It is safe for sensitive areas, and it's for topical use, but not for ophthalmic, oral, or intravaginal use. You would instruct your patients to apply it directly twice daily to mild to moderate atopic dermatitis, and then to stop using when signs and symptoms of atopic dermatitis resolve. If the symptoms do not improve in 8 weeks, then they would follow up with you. But in general, patients can use it for up to 8 weeks and then as needed afterwards. And it's a non-greasy, steroid-free formula. So it's great for women who have eczema on their face because it's not greasy, doesn't leave any residue. For people with facial eczema or areas that they don't like on the neck where, you know, ointments tend to mess up business clothes and clothing. So it's a nice formulation for that. So when you're choosing your patients, remember, patients have to be 12 years of age and older and have less than 20% of their body surface area affected by atopic dermatitis. And they have to have tried and failed topical prescription alternatives like topical steroids or calcineurin inhibitors. And there is usually a prior authorization process, but there are copay savings programs available. So eligible patients will pay as little as $0, and you can use your specialty pharmacies. We use a lot of those in my practice. And then take advantage of Incyte Cares. This is a great program, a patient assistance programs for people in need who are uninsured or underinsured and would be good candidates. I think that we often underutilize these patient assistant programs, and I encourage you to take advantage of those because this is a really effective medication, and someone who's a good candidate, we wouldn't want them to not be able to get it just because they're uninsured or underinsured. So that concludes my presentation, and I'll open it back up for questions in a minute. I think we have a few announcements.
So we'd like to thank our supporter again, Incyte Dermatology, for making this educational event possible. Please remember to join us for 2 more presentations with Dr. Linda Stein-Gold, which is going to be on August 9th, and also Dr. Adam Freeman on Tuesday, August 15th. So now I believe, Dr. Kircik, we have some questions from the audience.
Thank you. Thank you, Roxanne. And thank you, Heather, for that very eye-opening lecture. I actually learned a lot. It's I believe it's the first time I'm seeing this slide deck, and I think it's very commendable that Incyte took the time and consideration for the patients of skin of color to come up with this slide deck. I think it was very, very educational. So I do want to thank Incyte for their support and for this slide deck. Now, you did mention in the beginning that there were some differences in the disease state of the patient with skin of color versus the Asian patients. Do you, and those were sort of theoretical points that you made. However, do you see those differences in your clinic in real life?
I do. So I definitely think that I primarily see skin of color patients. So I do have that bias in that most of my patients are skin of color patients, but I do find that atopic dermatitis is more severe in my Black patients. And the other clinical finding that I think is in my clinical practice is itch. Itch is difficult to control and tends to be more severe in a lot of our skin of color patients. I would even say it's their #1 concern is itch. So I definitely see that in my practice.
So ironic that you brought that up because I am actually lucky. I practice in an inner city area, and my patient population is almost 30 to 40% African American patients. But what I noticed, and correct me if I'm wrong, a lot of the African American patients, they get worse in the summertime with the sweating, versus a lot of the white patients, they do get worse in the winter with the dry skin. And their itch gets worse in the summer.
I'll tell you, my opinion on that is, again, a little biased because I practice in Miami and it's always hot. That's true. So that is true. I don't have as much as a clear distinction between summer and winter. That's true. So it's harder for me to comment on that, but I can tell you from personal experience that definitely, I do think that sweat is aggravating. And actually, when we do clinical studies, we actually try to capture that. Do people get more itchy with sweat? And I do think people in Florida sweat a lot because, you know, we have 100% humidity 90% of the time. So I do think that could be contributory, but we don't have a winter here. We just have warm and warmer.
Yeah. How important do you think it is to include and to have skin of color patients in clinical trials, right?
Oh, I think it's extremely important. I love that analysis or the comparison I made to hypertension. Atopic dermatitis is a disease that's more common and more severe in our Black patients, just like hypertension, much more common, much more severe. And because of these large clinical trials that were done over the last 30, 40, 50 years, there's very clear algorithms on how to treat your Black hypertensive patients because they know that certain medications work better in that patient population. So I think that it will be wonderful, and I actually think that we are going to see this data coming out because this is definitely an area of interest that, and like Incyte did, it's really interested in looking specifically at this patient population to see maybe there are classes of drugs that work better, that should be first line. And I think just like hypertension, that would be very, very interesting to elucidate with research. So the focus is there. And I do think moving forward, we're going to see a lot of clinical trials that are powered to look at efficacy in different racial ethnic groups, because I think it will really impact our practice. We might be surprised and find some classes of drugs that really work significantly better based on the different immunology and genetics and different racial ethnic subgroups.
Right. Also, people want to know what's your regimen, right? We all use the prescription products and the drugs, but most of us do recommend some moisturizing, some cleanser. Especially, it's really an interesting question that comes up all the time. Which one do we apply first, the moisturizer and then the drug, or the drug first and then the moisturizer?
So this is a great question. I always say medication first and then moisturizers on top, but I think skincare plays a tremendous role in atopic dermatitis. So I do emphasize really good skincare. It's just as important as our pharmaceuticals, because if patients are not moisturizing their skin, it's very hard for them to get better. So I always recommend medication first. So I would apply the Opzelura first and the moisturizer on top. And as I mentioned in my talk, it's a cream, so it absorbs in well, and it's well tolerated on the face. So women who are wearing makeup, they can use it under makeup. For people who have eczema on their neck, which is a very common location for eczema, and I've had lots of men complain about ointments messing up their clothes, like you're wearing a collared shirt there, and if you had eczema on your neck, it would really destroy that shirt. So it's very well tolerated on those types of areas where people don't want to use greasy ointments.
So I think I just want to confirm and reassure our audience that unlike the topical steroids, we can use this a non-topical steroid any location on the body. We don't have to worry about the effects that we see from the topical corticosteroids, correct?
Yes, that's correct. So sensitive areas, face, neck, underarms, groin, all of those areas that are really challenging to treat in people with eczema.
Perfect. Well, we are almost getting to the top of the hour there. I thank you very much for your very eye-opening lecture, and hopefully we also add some treatment armamentarium for our audience for atopic dermatitis. I thank you so much, and I wish good evening to everyone.
Thank you.
Good night, everybody.
Bye-bye.
Bye.